Hello and welcome everyone, those of you attending in Mathematica's DC office, as well as those of you who are attending via webinar. I'm Ann Person, and I'm the director of Mathematica's Center for Improving Research Evidence, or CIRE. Mathematica's vision for CIRE is that it should help to bridge the gap between policy research and practice by offering tools and expertise for planning, executing, and using research from an array of diverse program and policy settings. We do this in three primary ways. First, by building capacity to understand and use evidence. Second, by planning rigorous and relevant evaluations. And finally, by helping to improve research methods and standards. We're here today to talk about rapid cycle assessment and the opportunities and challenges that both researchers and practitioners face as the demand for this kind of analysis is growing. I'll introduce all of our panelists individually, but before I do that, I want to give folks a sense of what to expect from today's agenda. Andy Feldman will kick things off by providing some opening remarks to frame the discussion. He'll be followed by two Mathematica researchers, Randy Brown and Peter Chauchet, who will speak to two specific types of rapid assessment, one focusing on program improvement and the other focusing on the assessment of program impact. They'll be followed by short remarks from our guests from federal agencies, ACS and CMS, as well as New York City's Human Resources Administration. We'll wrap up then with a panel discussion, which I have the pleasure of moderating, and then we'll turn it over to what I hope will be a robust Q&A session with both our in-person audience and our webinar audience. With that, let me turn to introducing our panel of experts. First, Andy Feldman is Special Advisor on the Evidence and Innovation Team at the White House Office of Management and Budget, which helps agencies to take the next steps in using evaluation, data, and innovation to strengthen results. Andy will talk to us today about the federal government's efforts to encourage rapid and rigorous evaluation, in particular through the Evidence and Innovation Agenda. As the director of OPRE, Naomi Goldstein is responsible for advising ACF's Assistant Secretary for Children and Families on increasing the effectiveness and efficiency of ACF programs. Today, Naomi will focus her comments on how her agency is trying to use rapid cycle approaches. Mathematica Director of Health Research, Randy Brown, is an expert in policy related to healthcare for the chronically ill, long-term care, managed care, and quality of care. He's nationally recognized for his evaluations of care coordination and disease management programs for Medicare beneficiaries. Today, Randy will talk to us about rapid cycle feedback for program improvement. Peter Chauchet is a senior fellow and senior economist at Mathematica's Princeton office, and he's played a leading role in many large-scale studies of programs such as Job Corps, Early Reading First, Early Head Start, Trade Adjustment Assistance, and the Workforce Investment Act. Peter will share his expertise with us about opportunistic experiments. Next, we have Angela Rashidi, who is Deputy Commissioner for the Office of Evaluation and Research with the New York City Human Resources Administration. We look forward to Angela's comments on how her agency uses rapid cycle assessment. Finally, Renee Mentnek is the director of CMS's Center for Medicare and Medicaid Innovation's Research and Rapid Cycle Evaluation Group. This group includes over 40 master's, doctorate-level economists, health services researchers, epidemiologists, sociologists, farmers, and other clinicians. She'll share her thoughts today on how her agency is using rapid cycle approaches. Now, before we get started with the content of today's forum, I just want to address some housekeeping issues. Please be mindful that our session includes the in-person audience as well as the webinar audience, so we ask everyone in the room to please silence your electronic devices. Also, the session will be recorded, so we may capture images of some of you here in the in-person audience. That video will be posted on Mathematica's website later this week. Silence those devices. At the conclusion of the presentations here, I'll facilitate a discussion first with the panelists. I'd ask that you hold your questions to after that when we actually open up the Q&A session. Now let me turn it over to Andy Feldman to provide opening remarks.
Okay, thanks, Anne. It's great to be here. Let me start off by saying why I think this topic is important and interesting. And that is, one of the reasons is because for agencies that are relatively new to the world of evidence building and using evaluation, these tools that we're talking about today, rapid, opportunistic, low cost, can be a great way to get one's foot in the door with agencies that don't have this kind of track record, because they are so connected to operational improvements. You can see the results quickly. So that's one reason. For agencies that are already strong in evaluation, traditional evaluation, which tends to be longer term, rigorous, in-depth, these tools that we're talking about today are, I would say, the next steps for those agencies in thinking about new ways to build evidence, especially quicker, more operational tools. The administration's evidence agenda is focused on helping agencies continually improve their performance by using existing evidence that's available, generating new evidence, and using experimentation to learn and improve. One of the milestones of that agenda was a memo last July, co-signed by 4 White House directors, office directors, that asked agencies to develop proposals in a few areas. That includes using already existing program data, administrative data, to learn and improve programs. The second one was using high-quality, low-cost evaluation and rapid iterative experimentation. A third focus was on outcome-focused grants. You may know an example of tiered evidence grants like I-3 at the Department of Education, for instance. And finally, strengthening agency capacity to use evidence. An example there is at the Department of Labor, the Chief Evaluation Officer role. And we also launched a workshop series that helped agencies develop proposals in all of these areas. So we've done 5 workshops so far for about 80 agency officials apiece. Focusing in on the element of that memo and our agenda that focuses on rapid iterative experimentation, which overlaps the most with today's topic. The memo encouraged agencies to build an evaluation in ongoing program changes, to use administrative data, like I mentioned, and also to do more low-cost experimentation. There are other efforts in government that are related to this topic that are worth noting. One is that there's a new social and behavioral sciences team. It's housed at GSA, and it's helping agencies to develop proposals to use behavioral insights from behavioral economics and behavioral psychology to do often rapid operational improvements. There's another OMB memo worth checking out if you don't know about it. It gives best practices about using administrative data. And finally, there are initiatives by leading agencies, and we're going to hear about 2 of those at the federal level on the panel today. In terms of other related efforts on rapid cycle assessment, there is, first of all, the powerful example from the private sector where especially tech companies are doing hundreds or thousands of experiments per year and doing often small operational changes or larger changes based on those. That's a powerful example for the government. There's also the UK Behavioral Insights team on which our new team at GSA is modeled. There's the Poverty Action Lab at MIT, which has a new office, the North American office, which is trying to connect researchers with programs across the country to do more randomized control trials. And finally, I would point you to Paul Decker's address. Paul Decker's the president of Mathematica, but he was also the former president of APAM. His address, presidential address at APAM, focused on reducing fear among program managers related to evaluation. It relates to many of the themes we're talking about today. One final one to mention, I see John Barron in the room from the Coalition for Evidence-Based Policy. His organization has launched a low-cost RCT contest, and the winners, I hear, are going to be announced imminently, so you can check that out. Very briefly, 2 key challenges in the public sector that our topics today relate to. One is that too often, agencies and programs see evaluation as too slow and backward-looking to be directly relevant to operational decisions. It can be seen as threatening, especially up or down evaluation, where you decide, does this program work or not? And it can be seen as costly. This doesn't undermine the importance of traditional evaluation, especially long-term studies, where in some cases outcome variables take a few years to determine whether this works. So the tools that we're talking about today are really supplements and complements to that traditional evaluation, but can address some of these challenges. And second of all, in government, we're very good at setting up processes, standardizing them, focusing on accountability. We're less adept at creating feedback loops for learning. And the topics that we're going to discuss today help us do that. To do this kind of work requires bridging silos within public agencies, between program administrators and evaluation experts and performance management experts and data experts. If those folks are in silos and not helping each other, this work is going to be slowed. One reason why bridging these silos are important is because some of these tools are complementary. They're different and complementary. For example, program evaluation and performance management, two different tools, but if they work together are complementary. And I just want to give an example of why they are complementary. Performance management is very relevant to program operators because it's pretty quick. It can have outcome measures and output measures that are directly relevant to operational decisions. An example is HUD-Stat at the Department of Housing and Urban Development. They meet every few weeks with different agencies to review measures, see what's working, what's not, and make improvements. Very valuable. What performance management is less able to do is think about impact. And that's where program evaluation comes in. And one of my favorite examples to illustrate this is from the supported work demonstration, one of the first employment and training programs to be rigorously evaluated. Here are the outcome measures for the people in supported youth. Youth did the best. 63% got a job within the first 2 years of graduating from the program's ending. Adult men, second best at 57%. Adult women did the least well at 49%. If you only looked at these performance data, you might think that youth did the best. You might also think maybe we should shift resources from these other groups to youth. But supported work also had a rigorous evaluation where there was a control group and random assignment to a control group and a program group. So let's look at the data from the control group. And here it is. What you can see is that youth in the program did just as well as youth outside the program. Okay, no gain. Adult men, about the same. Adult women is where we see the only significant impact. In other words, based on this evaluation, this program only works for adult women. It's the exact opposite conclusion that you might draw from just the performance measures. So it's an example of how these different analytical tools are all useful, but can be complementary. A final slide to sum up here. I think our goal in the government and external stakeholders is to dramatically increase the rate at which we build and use evidence. But to do that, we're going to have to increase the volume of studies. We're going to have to lower the cost. We're going to have to draw on existing resources, especially in-house data. The tools that we're talking about today are terrific ways to do that. And as we do that, we're going to have to keep bridging those silos and realizing that each of these tools has strengths and weaknesses that we have to be thoughtful about. So that's some framing comments.
Thank you, Andy.
Sure.
Let's turn it over to Randy.
Dan's here. Hi, can you hear me okay in the back? Okay, good. I was interested to hear Andy talk about supported work. That was the first project that I worked on at Mathematica when I started 37 years ago. I'm glad it's still relevant. So you may have heard a lot lately about rapid cycle feedback. It's one of the big buzzes in DC. And what I'm going to do talk about very briefly is what this means and when it's used for for improving an intervention or a program. what its appeal is, what some of its drawbacks are, and give an example. And I'm going to be talking mostly about what is occurring in federally funded research in the health area. So rapid cycle feedback is designed to provide ongoing feedback on performance of a program or a process, and it helps program operators and sponsors monitor their progress. The idea is to figure out whether outcomes of a process are moving in the right direction so that the program operator can then delve into why, if they aren't, and try to improve. And on many federal contracts, especially in health studies, this rapid cycle feedback is being done centrally through monitoring or evaluation contracts or TA, technical assistance contracts. And when it's used in as part of an evaluation contract, it's a very big departure from the way things were done in the past, where there was this aloof evaluator approach, where it used to be that that the evaluator should avoid at all costs the influencing an ongoing demonstration. Now, in many cases, evaluators are expected to help agencies make a program work while still evaluating them objectively. And I want to also note that rapid cycle feedback includes not just numbers, but what does the evaluator observe in the process of care that may be limiting their performance. So there are definitely some pros and cons to rapid cycle research. The advantages are that you can identify implementation barriers and lack of fidelity of the program quickly and help ensure that what you're testing is what was planned for the intervention. The second thing is that it improves the chance of a successful intervention. They're expensive to do. They're usually based on a good idea, so you want to get the most out of this good idea. And the third thing is that the advantage is they shorten the learning time and reduce the cost of doing this sequence of studies. You come up with an idea, you run it for a while, observe the results, then you test it, find it doesn't work, come up with a new idea, let it run. This is designed to short-circuit that and get to meaningful improvements more quickly and less expensively. But there are some disadvantages, of course. It creates potential conflicts of interest if the evaluator is evaluating their own advice. It was the reason for the aloof evaluator approach to start with, or one of them anyway. It's a bigger problem, though, is that if you're continually tinkering with the program, how do you know when you evaluate it what it is that you've evaluated, given that many interventions take unknown lengths of time to influence outcomes enough to be detected? So most health problems are not like a manufacturing process where you change something and you see something results immediately, or you take aspirin, your headache goes away. Reducing costs or hospitalizations is a lot trickier concept that can take a longer time. And the result of this is that rapid cycle feedback may lead operators or programs to decide too soon that an intervention or process change isn't working. And then jump to something new when they haven't given a full chance for the latest change to have an effect. So I'm going to talk about very briefly about one tool for rapid cycle studies, and that's statistical quality control, also called statistical process control or control charts. The methodology was developed by a famous statistician named Schuhart and adapted by Deming. And it's widely used in marketing and for manufacturing quality control processes. It's a non-parametric method for identifying outcome shifts and trends from plots of data. And you look at sequences of outcomes to see whether there are sequences that are highly unlikely to occur if there's no real shift in the level or trend. It's unlikely to be due to chance variation. And this method is currently being required for several health studies. A couple examples. It's being used to monitor the performance of transitional care programs on reducing the 30-day hospital readmission rate. There are monthly data points that are created. Another is the Health Care Innovation Awards projects that are funded by the Centers for Medicare and Medicaid Innovations, and the Partnership for Patients program for hospitals. So this chart, borrowed from a presentation by Rocco Perla from CMS and his colleagues, gives a nice illustration of how statistical control charts can help. If you look at the bar graph on the left-hand side, it shows the mean values before and after some change. and it shows a significant decrease in, let's say, costs as the outcome measure. On the right-hand side, you see three alternative sequences of points over the pre-test and pre- and post-change periods. They have the same means in each of those two periods, but very different patterns and implications. The first one shows that the initial decrease in trend before an initial decrease in the trend before the change, and then looks like kind of a shift downward in the trend afterwards. The second graph shows just a continuation of in the post-change period of the downward trend that was already observed in the pre-period. And the third one shows this flat pre-period followed by a sharp drop in the level afterwards, and maybe a creep upwards later in the period. So as there are a lot of different varieties of statistical control charts and tools for interpreting and refining those methods that I don't have time to talk about today. But like other rapid cycle feedback approaches, there are pros and cons of these charts. The advantages are that it's quick, it's robust, it's intuitive to explain, and you can detect important shifts that might be masked by just differences in a pre and a post period, like the previous slide showed. But there are a number of disadvantages, though, and one is that there may be other factors at work in the environment that are outside the organization's control, and so unless you have a comparison group to see what that pattern looks like over time, you don't really know whether it's your actions or something external that's causing these changes. Small sample sizes is another potential problem. It leads to really noisy graphs that make it hard to detect the signal from all that noise. A third issue is that even if you find a change in outcomes, it might be hard to tell which program component is responsible. Multiple things are being changed. Well, what was it? And lastly, like for most health outcomes, there's no good way to tell how long it's going to take for a program to influence outcomes enough that you can detect them with tests. So it's hard to tell when you think you ought to change a process, and when you do, when you should expect to see an effect on the outcome. So that's enough for me. I'll turn it over to Peter now. Thanks.
Hello, I'm Peter Chauchet. It's a pleasure to be here. So I want to talk about another branch of rapid cycle evaluation, which we call opportunistic experiments. Some others call them low-cost experiments. So those are really the same thing. And the way to start is to differentiate this type of study from what Randy was talking about, because the idea of opportunistic experiments is that they address causal impact questions. And what I mean by causal is you really want to know how individuals who were offered an intervention fare relative to how they would have fared if there wasn't an intervention. So in order to do that, you need a well-defined control group, as Adam was talking about earlier. So, Andy, sorry. So the basis of these opportunistic experiments is random assignment to program and control groups. Now, a critical part of what an opportunistic experiment is that it's built into a planned intervention policy or practice. The idea is to exploit opportunities to build a rigorous study into an intervention that's going to be happening anyway. That's really critical here. Another critical feature is that these experiments, they are initiated by state or local entity to inform policy decisions that they're making every day. So they have low disruption because they're occurring anyway. And another critical feature of these is that there should be easy access to data about key outcomes. So a lot of these studies are going to be based on administrative records data, which are getting better and better across all agencies. Now, they could be low cost, but just because they're low cost doesn't mean they necessarily have to be small scale. Okay, so to get a little bit more concrete here, how does one identify an opportunity? Well, consider 4 scenarios. The first is agencies, programs often pilot new interventions. So they usually do that in some selected sites. But why not have a pool of volunteer sites and take half of them randomly to be pilots and half not? And you follow both over time, and you have a nice randomized comparison, and you really learn what works. Again, the entity is doing the pilot anyway. So you're just building the design into the existing plans. A second way you can have an opportunity is often programs want to roll out a new intervention, but they either don't have the resources or don't want to roll it out all at the same time everywhere. So one way to do this is to stagger it and have, let's say, half the sites have the rollout in the first year, and in the second year, all the sites can get it. So in that first year, you have a nice randomized trial where, again, you're exploiting an opportunity. The third is if the intervention involves some kind of a communication, sort of increasing recruitment or outreach or information about the program, that's a perfect opportunity to try and test out different types of interventions that can be fit very easily into a random assignment design. That type of effort is used very much in the private sector. It's also used very much in the political arena. The last one I want to talk about is you can build an experiment if there's program oversubscription. So if there's more people applying than there are program places, you can do a lottery randomly and have a nice random assignment study. An example of this is an evaluation of charter school programs, which have exactly this type of setup, and you can learn quite a bit. Okay, so I'll just say a few words about how can this all work? How can we facilitate successful experiments? And to me, there's some critical issues that need to happen. First, there has to be strong partnerships between agencies, policymakers, and research. Each bring various skills to the table. Obviously, the agencies, they know what their plans are. They know what the interventions they want to test might be. The researchers clearly can see if help define the research questions, see if there are feasible designs. So there has to be a strong partnership. That's a real prerequisite here. The second one is this can't be a one-time operation. This type of thing has to be built into the normal program business operation. So it has to be phased into the planning phase in order for this to really be successful on an ongoing basis. Third, from the government funder's perspective and the researchers, it's imperative that we develop tools and training so that explain what opportunistic experiments are, how to identify them, and how to conduct them. Now, Mathematica, through funding from the Department of Education and also HHS, we are starting this process by developing guides for different audiences, as well as software development that will do impact estimation. So once you get your administrative data, you could throw it into the software, and out comes these nice, rigorous analyses and well-formatted tables. We're working with some states now to try to pilot test some of these products. Okay, finally, I thought I'd give just a little schematic here of what sort of steps local agencies would need to think about in order to sort of implement this on an ongoing basis. So there's 5 steps here. The first ones are all intermingled with each other. And that is that the local agencies, they need to have a research agenda, identify research partners, and identify opportunities for experiments. And these things are all connected. Therefore, the arrows are all connected. So once an opportunity is identified, step 2 is recruit participants. Now, for us researchers, the hardest part of our evaluations are to recruit people. The idea here, and I think a huge benefit of having having this be initiated by the local folks, is that it could help recruitment. So step 2 could be typically easier than it is in random assignment studies that are done currently. Step 3 is you need to conduct and monitor random assignment. And what I'd like to emphasize there, it's critical for any random assignment study that it's verified that the treatment group, the program group gets the treatment, and that the control group doesn't. And so that's step 3. That monitoring is a very important step in order to ensure the rigor of any randomized trial. Step 4 is collecting data. And again, this is mostly going to be administrative data. The intent here, again, is that having the local agencies participate in this might facilitate getting the data. So that step might be easier than it's typically done today through an outside evaluator. Finally, step 5 is to analyze the data and report findings. And what I really like to emphasize there is I think reporting the findings, just not to the local areas themselves, but in a broader forum, is very important in order to start building an evidence base of figuring out what works. So step 5 is very important too in terms of presentation and publication. That's it for me. Thank you.
All right. Thank you. Then we'll turn to Angela for her remarks.
Hi, everyone. Good afternoon. So as Ann mentioned, I'm the Deputy Commissioner for the Office of Evaluation and Research for the New York City Human Resources Administration. I'm going to just call it HRA from now on. And I was asked to talk a little bit about how we as an agency, as well as my office, use rapid cycle evaluation. So just to provide a little bit of context, so HRA is a local social service agency. We're the largest actually in the country. We serve at any point in time about 350,000 people who are receiving cash assistance and about 1.8 million people receiving supplemental nutrition assistance program benefits. And I'll just call that SNAP from now on. We also run Medicaid and other programs, but our work, so the Office of Evaluation and Research, primarily focuses on the SNAP as well as our cash assistance programming. So I head up a small research and evaluation team. It's an internal team. We have a small staff, but we really, for the agency, conduct program evaluations. HRA does have a fairly long history of using data for program operations. You know, they have a full array of stats. They do a lot of performance measurement. And so, you know, the use of data is very embedded in the culture of the agency. My office was established in 2007 to really take that to the next level and to try to implement more rigorous evaluation to see how effective programs are. So in terms of talking about rapid cycle evaluation, I would categorize much of what we do as rapid cycle evaluation. We typically use, in many of the evaluations of our pilot programs or even ongoing programs, kind of a two-stage design. One, we are assessing the implementation, and we do a lot of qualitative work around that and really look at, you know, how is it implemented and are the goals in terms of implementation being met. Then the second stage really is looking at the impact, and that's where I think we differentiate our work with the performance management work that happens in another part of the agency. So our office is really focused on that counterfactual and how effective are the programs that we're looking at. We always build in interim feedback points to get to the point I think Andy made earlier about the importance of that. So it's not just us coming in and say, all right, we'll see you in a year or two with the final outcome. We always build in interim feedback points, not only on the implementation piece, but also on the outcome piece. So I'm going to just briefly describe 2 or 3 examples of how we've done this and how it's been received by the program managers. So the first project I'm going to talk about is related to our SNAP. And the agency, HRA, is involved in a fairly major process reengineering effort. And one of the first major projects as part of that effort was to move in the SNAP to move towards more self-directed model. And so really the first project was implementing computer banks in the SNAP centers so that people who physically came to a center to apply would actually be steered towards or encouraged to apply online in the center rather than seeing a worker and doing it in person. And so we were asked to come in and take a look at not only how it was being implemented, but also what the impact of that was on SNAP enrollment rates, so looking at the acceptance and rejection rates for those applications. So what we did, and we used the same sort of two-step model I described earlier. We first went in, we did client surveys, we did observations, really looking at how it was implemented. What we found from that is that it was implemented very well according to plan. Clients were fairly happy with it. Staff were happy or neutral. There wasn't, a whole lot of strong feelings either way, which, was good since it wasn't all negative. And so then on the outcome side, what we did, it was piloted in 6 centers initially, so it wasn't random assignment, but it gave us a fairly strong comparison because it was, implemented in 6 centers that were not all that different from previous centers. So what we did was we looked at acceptance rates from pre to post period, compared them to the other centers, and compared them to what had been happening a year prior, because SNAP acceptance rates are fairly seasonal. And what we found there actually was there was a pretty dramatic negative impact on acceptance rates. And I think initially the program managers didn't take that very well, or they didn't really want to believe it. But because we had done, all of the implementation work, we were involved in all of the planning, we were at the table, eventually, it came around, and we really found that it was because people, they had to leave. After they applied online, they had to go home and get a telephone call for an interview. So we found the interview completion rates dropped dramatically. And so having that strong comparison group, I think, is really what eventually convinced the program managers that they were having, or that the model was having a negative effect. It led to some immediate changes in how things were being implemented, and eventually it actually led to they stopped expanding the model until they could fix some of the things that were not working as well. So that's one example, and that entire evaluation took 5 months. And we relied on primarily administrative data on the implementation side. It was mostly data collection in terms of the client surveys, but on the outcome side, it was all administrative data. And so that's sort of the largest example I can give. The second one is currently in process of being designed, and it's actually somewhat related. It's an intervention to implement robocalls for people who have an interview scheduled via the telephone for the SNAP or cash assistance, or who have missed appointments. And so what we're currently planning now is just to randomly assign those robocalls, and then to compare the interview completion rates for the 2 groups. So that one's very simple. But I will say there was quite a bit of resistance at first to doing the random assignment, and they were for legitimate reasons, completely legitimate reasons from the program area. But it was a little bit of a challenge to convince the program managers that this was really the only way we could do it, because there's so many things going on with the SNAP program that they were doing it citywide, so there really was not a comparison group other than doing random assignment. So it looks like we are going to be able to do it that way, and it'll actually be very easy. And the volume we have is so high that we really only have to run it for about a month or 2, and we're going to have a very large sample, and it's probably the easiest evaluation we'll ever do. And then just real quickly before I run out of time, a third one we're doing is also random assignment, and it's looking at our fraud department wanted to see if different messages in the online application led to more accurate information being provided. And so they're placing the messages either at the front of the application or at the back of the application, and also testing out different messages. And so we worked with the contractor for the online application to randomly assign what message people are going to get, and then we're just going to compare the accuracy of the information. So those are just 3 kind of quick examples, and just a couple, key takeaways that we've somewhat already heard, but what has been successful for us is that strong partnership between the researchers and the program managers. We have the benefit because we're an internal team, so we know the data, we know the key players, we know the processes, but that type of relationship can be developed with outside evaluators as well. But that's really, really key, I believe. And then also just really, continually talking about the importance of that counterfactual. Program managers are they do a lot with monitoring data. It's just they often are so consumed by what's going on a day-to-day basis, they forget that they have to have a comparison to really see if what they're doing is effective. And so really sort of instilling that in everything you do, I think, is very important.
All right. Renee.
Thank you. I'm Renee Metnish. I'm the director of the Research and Rapid Cycle Evaluation Group in the Innovation Center at the Centers for Medicare and Medicaid Services. Our group had a predecessor organization in a former part of CMS called the Office of Research, Development, and Information. In the Affordable Care Act, the Innovation Center was established to test innovative payment and service delivery models to reduce program expenditures while preserving or enhancing the quality of care furnished to the individuals that are participating in those model tests. The Innovation Center Authority is very broad. We are testing many different models around how to reform both the payment and the delivery system, around experimentation with bundled payment, accountable care organizations, new forms of medical homes. We're working with the states through the state innovation models to try to help the states jumpstart innovation in their respective states, dealing with whatever their own context might be. We're looking at many Medicaid models, looking at how to improve birth outcomes and reduce the rate of preterm births. And we were given a very broad agenda with substantial resources to go along with it, and an expectation that we would make an impact and that we would be able to observe those impacts very quickly. There was a sense of urgency with trying to deal with the challenges facing the healthcare delivery and payment systems in the country. So earlier evaluations under our former authority assumed that an intervention was static and over time, and that models wouldn't necessarily, we called them demonstrations, they wouldn't necessarily change in a real-time way. An evaluation would sort of come in during the course of the evaluation, but the point wasn't trying to kind of influence or change what the design of the intervention might look like during the course of the intervention to improve chances of success. We've switched or evolved into a new mindset where our goal is not only to observe the impacts as have been described here, but also to create a culture and a paradigm where we have the opportunity to promote success. The Innovation Center models require fundamental changes in the structure of the healthcare delivery system. It includes realigning incentives across multiple providers, across multiple payers, which is another shift from the way that we used to operate. Right now, we believe it's important in order to really reform the delivery system to have a critical mass of payers at the table. That creates, obviously, evaluation challenges, but is an exciting way to try to implement a model. As I said, to enhance our chances of success, we believe substantial learning and adaptation is necessary. Again, that creates a different culture where the evaluation team is actually part of the solution. Just briefly, I'm going to talk about sort of 6 general principles that are guiding us right now in the way that we conduct current evaluation approaches, and then talk a little bit about 2 specific ways or examples. As I've mentioned, we communicate and make clear that we are to be part of the solution. So we plan to gather information and leverage our claims data to promote and support a continuous quality improvement environment in the marketplace. We emphasize the need for close collaboration with the program team, and we emphasize the need to be responsive to their needs and to the participants' needs. So we are creating a lot of products and output from our evaluations that are used as feedback back to the model teams as they oversee an intervention, and back to the sites themselves so they can see on a real-time basis how they're performing. So sort of the key take-home from that being part of the solution is that we're intentionally blurring the lines between formative and summative evaluation. A little later, when I talk about a specific analytic example, I'll show you how, or talk a little bit about how we're blurring those lines. We believe a second principle is that having a comparison group is important. We don't, because these are delivery system and payment reform kinds of innovations, we don't always have the opportunity to do randomization, but we are in the process of trying to develop some sense of when does it make sense to do randomization and when does it not make sense. If what we've been doing is constructing comparison groups, and that's actually not different from what we've done in historical evaluations where we've constructed comparison groups from existing data systems. We're very fortunate on the Medicare side, and increasingly fortunate on the Medicaid side, to have available to us a very rich administrative database that allows us to identify comparison groups that are matched either in terms of provider matching or beneficiary matching. But again, we try very hard to construct comparison groups. That's not always possible to construct a comparison group. I think a good example is the model that Randy mentioned, the Partnership for Patients, which really involves a large subset of the hospitals in the country. So there aren't very many comparison groups available. And in those cases, we really do try to rely on the statistical process control chart methodology to observe trends over time. So we're constantly watching those trend lines. But even when we don't have a randomized design, we're trying to make sure that we've matched our comparison groups as closely as we possibly can. The third principle is speed. One of the constraints that we had in the past is access to administrative data in a real-time, 100% way. Our data systems, claims, and enrollment information have substantially improved to the point where we have access to 100% claims data and hopefully in the not-too-distant future, encounter data from managed care plans that allow us to look at the entire population fairly soon after a service is rendered. In the past, we would have to wait almost a year before a file would be available to us that we could use. That's no longer the case. We're building an environment with the contractors that we work with can also directly access that claims data in a real-time way. That allows us to create monitoring reports, and it allows us to construct rigorous kinds of evaluations that we can feed back quickly so that we can get a signal for what's going on. We do, though, try to balance looking too quickly. We do run the risk if we look too quickly, and Medicare data in particular and Medicaid data as well, when you're looking at expenditure patterns, that data is very noisy and very volatile. And if you're looking at it too soon, it's hard to observe a trend. So while we're looking at the data on a quarterly basis to try to draw some conclusions, we are cautioning folks that you do have to have a few data points before you can start to observe a trend that you can sort of believe. Our fourth principle, and a very important one, is rigor. So wherever possible, we're using advanced epidemiologic methods to measure the effectiveness of our models and trying to achieve a high standard of evidence, because the next stage of any model test that we implement is before it can be scaled up to a larger program, it has to go through a certification process with our Office of the Actuary. That's the way the statute was written. And they would require that there be evidence that's believable, so our evaluations have to be designed in a way that's credible to them. So rigor is important. However, in some cases, we lack baseline data, and sometimes we lack comparison groups, and in those cases, we try to make the best of the data that we have. And so we have to balance this rigor against setting the bar too high. So the standard in the past has been using sort of certain confidence levels and p-values of 0.05 and having 95% confidence. Well, so sometimes in model tests that involve changing delivery systems, that's a hard bar to pass. It's a hard needle to move. So we're looking at whether there's merit to sort of, because these often are not clinical trials. It's not about proving if a particular drug is more effective than another drug. This is this payment system or this delivery system reform better than what we would have observed had we not made the change? And perhaps the level of confidence could be a little less rigorous than what you would do in a drug trial, as an example. So we're exploring some of that. We're also exploring, and I probably should stop here and talk a little bit about the example that I wanted to highlight, which is wherever possible, and I mentioned that we do quarterly snapshots of the data. And the Mathematica team was one of the first teams to help us do this, where we're producing quarterly reports using regression-based difference in difference analysis, typically a fixed effects kind of model, where we're then looking at an estimate around a measure like cost in a particular quarter, and we're looking at the confidence intervals around that impact estimate, and we're redoing that analysis every single quarter. So we're looking to see, for example, on cost, is the coefficient on that measure sort of going down over time? Is it trending in the right direction? So statistical significance is one thing we look at, but the other thing we look at is the estimate going in the direction we want it to go in. From the medical home models that we've been looking at, it looks as if by the time you get to about 3 or 4 quarters out, you should start to see a little bit of a signal. Some of this, though, depends upon, and we're very mindful, it depends upon how long you think it will take for a particular intervention to actually have an impact. So a medical home model, while it would be nice to be able to observe an impact 3 or 4 quarters out after the start of a model, we also recognize that change takes time when you're talking about reforming how a physician practices at the point of care. So there's a startup involved in them in sort of getting into the groove of how to change what they do. So it wouldn't be surprising that while we're looking on a quarterly basis and using these sort of rigorous regression-based approaches, it wouldn't be surprising to not observe anything till maybe 6, 7 quarters out. But we're constantly looking and we're constantly feeding that information back to the leadership and the program team. The other, I think, principle that's important to highlight is we believe it's really important to understand the context. It was mentioned previously by a couple speakers that qualitative information is really important. So we have, in every evaluation that we do, a fairly robust data collection, and the collection of qualitative data is not a cheap endeavor, but focus groups and site visits and surveys around beneficiary experiences. We spend a lot of time on the ground with the model participants, the providers that are helping us run these model tests, to try to understand how they're implementing the model. The how part is really important to discussions about scaling something up to a larger program, because when the actuaries look at what we achieved in the context of the model test, they'll have to take into account how representative the participants in these models are or were of what the delivery system providers beyond the participants might look like. So, what you might observe in a model test may not be exactly what you would observe in a scaled-up program-wide model simply because of the selection of the providers in it. So understanding the context is very important. We study the process. We ask the providers to report how they implement these different models, and we do that fairly regularly. Our goal is to generate impact assessments early after implementation and often over the course of the model in the hopes of identifying and scaling successful programs as soon as possible and promoting model refinements and potential improvements over time as preliminary results are generated. I want to highlight an example, and actually it's an example of a project that Randy is working on with us, and it is the evaluation of the Comprehensive Primary Care Initiative, which is a Medicare medical, actually it's a multi-payer medical home model. Some of our early focus has been on the Medicare part of the population for some data issues. An example of how this currently is working is we have collaborated very closely with the program team. So our group is the evaluation team, but in the Innovation Center, each of these models is being run by a program team that has responsibility for the oversight, implementation and oversight. So we work very closely with them in creating a practice survey. Then we took the results from that practice survey and we fed it back to both the program team and another team called the Learning and Diffusion team, who work with the model participants around ways that they might improve what they're doing. So the practice feedback information is constantly being fed back to them in a learning environment. We also were interested in the practice's perceptions of technical assistance, because another part that's important to the culture of the Innovation Center is just changing the payment delivery system by itself without helping through technical assistance, may not result in as much success. So we provide a lot of technical assistance. We survey the practices or ask the practices how they're, what they felt about the technical assistance. We took that information and fed it back to the group focused on providing the technical assistance. So just as a closing point, I want to say that we are in the middle of a culture shift in our organization. It's been fun. It is definitely challenging, and I think we're all learning as we go.
Thank you. Let's turn finally then to Naomi.
Thank you. So Renee speaks from the health side of the Department of Health and Human Services. My agency, the Administration for Children and Families, is on the human services side. Sometimes we work together on common interests. For the most part, my agency doesn't provide services directly, true for Renee as well. We make grants to states, tribes, territories, and local organizations to provide services. And so our interest in opportunistic or rapid experimentation is primarily about helping these entities to plan and carry out such experiments. We have a strong history of traditional, long-term, large-scale, in-depth experiments, which often have been opportunistic. So the outstanding example would be the experiments required under AFDC waivers in the 80s and 90s, where a state wanted to change some aspect of AFDC policy, and the federal government said, well, okay, you can change it, but you're going to have to run an experiment to find out whether it worked. So very much opportunistic, but not necessarily low-cost, small-scale, or short-term. In 2010, we started a project called the Behavioral Interventions to Advance Self-Sufficiency, or BIAS for short. And the driving idea of this project was to apply ideas from behavioral economics to human services. Human service programs, like many other programs, are often based on an implicit assumption that people are perfectly rational beings with perfect information who will carefully consider various options before making choices that maximize their well-being. This is the model of classical economics. Behavioral economics brings in what we know from psychology about human behavior, that all of us procrastinate, get overwhelmed by choices, miss important details, and may make choices that don't support our well-being or even our own self-defined goals. So the BIAS Project invested heavily in reaching out and convening state and local human services staff to explore how these ideas might be applied to human services. So trying to build those relationships that other speakers have emphasized. The project used a process of behavioral diagnosis and design to understand how behavioral principles might inform the development of improvements for testing, rather than taking a strictly opportunistic approach. So not just swooping in and saying, oh, gee, you were planning to do something, maybe we could run an experiment and see how it works. But investing in a prior step to say, oh, let's look together at some of the problems that you are facing in achieving your goals or helping your clients achieve their goals, and figure out what kinds of low-cost adjustments might hold promise. So this is a slightly different angle from the opportunistic experiment framework, but there is a lot of overlap. The emphasis has been on low-cost adjustments to practices that hold promise for yielding short-term, easily measurable improvements in program effectiveness. I want to describe one example, and this is from the child support context. Nationally, the average non-custodial parent who is incarcerated, so this is not quite English, so absent fathers, typically, non-custodial parents who become incarcerated lose their ability to earn income and on average leave prison with more than $20,000 in unpaid child support. So that is accumulated debt or arrearages, which are difficult to pay and can pose an obstacle to gaining regular employment after release. Most states have adjusted their laws to allow incarcerated non-custodial parents to apply for modifications to their child support orders. But consistent with the model of human beings as not being the rational actor all the time, Texas in particular found that relatively few incarcerated parents responded to an invitation to apply for a modification in their child support orders. So the BIAS Project worked with the Texas Attorney General Child Support Division to design improvements in the process aimed at increasing the take-up rate. The improvements included things like sending an advance postcard before sending the letter with the forms that needed to be filled out, redesigning the materials to be simpler, pre-populating the application with information that the Attorney General already had, and using language that appealed to the recipients of the letter, that appealed to their identity as a parent rather than their identity as a prisoner. If you think of yourself as a parent, you may be more likely to take action for the benefit of yourself and your family than if you think of yourself as a prisoner. And finally, sending a reminder. So these are things that sound like common sense. If this were a forum on behavioral economics, I'd go into some detail about how the changes were designed based on behavioral principles. But I'm going to skip over that. You can read about it in a recent report that we've issued, and there's a short two-pager in your packet that can lead you to finding that report online. So nearly 2,000 incarcerated non-custodial parents were randomly assigned to receive standard materials or the revised materials from May to July of 2013. Responses were tracked through December, so like the New York experiments we heard about it, a pretty quick timeline. And if you want to know what happened, you have to stay tuned. We expect to publish a report with the results very soon, and in your second handout, you can see where to sign up for our newsletter so that you can be the first to know. I just want to finish with a couple of So I wanted, before my broad comments, I wanted to mention that Office of Child Support Enforcement in my agency has published a forecast indicating their intention to make available a grant opportunity for states to build on and expand this kind of behavioral experimentation in the child support arena. So we're very excited about that. Engineers talk about the iron triangle of quicker, better, and cheaper. And the conventional wisdom is you can pick any two. So if you want it quicker and better, it's going to be more expensive. If you want it cheaper and quicker, it's going to be poor quality. And I think in a lot of areas of life, you can find that this holds true. But we can do all three sometimes. And this has got to be true because I know from painful experience that it's possible to do things slower, worser, and more costlier. So it's got to be possible sometimes to do things quicker, better, and cheaper. And I think the advent of these low-cost experiments, whether strictly opportunistic or planned, really presents a potential paradigm shift where we're on the verge or perhaps even in the early stages of finding out that things that we thought were impossible really aren't.
All right. Thank you. So before we turn it over to the audience, for question and answer, I want to prime the pump a little bit with some discussion among the panel members. And I'll start with a few sort of higher level, more general questions. And forgive me, I'm going to stand because I had to crane quite a bit to see the folks down at the end. All of these changes that we're talking about testing, whether it's through the kind of iterative feedback Randy's discussed or opportunistic experiments per Peter's discussion, we're testing innovations. And yet we know that innovations can take time to really yield any results. So I'd love to hear from you all. And we don't necessarily have to go down. Sorry. I'd love to hear your ideas about when is the right time to actually evaluate? When is the right time to apply some of these methods, given that the programs are new, that innovations take time, and in some cases, if we can call it an intervention, the program is actually changing as we're studying it. When is the right time to really zero in?
I can react. I think evaluation needs to start at the very beginning, if not even before something is launched. That notion that something is changing over time is actually important information to capture that helps sort of inform where you might want to be a year or 2 years down the road. So I don't think it's ever too early to begin. Even if but I think it's important to recognize and have kind of a realistic set of expectations about how quickly change actually happens.
Naomi?
So I would agree that it's always the right time, but I think having a spectrum of intensity available to you is really helpful so that when you are just trying something new and you don't have a fully developed model where you want to implement with fidelity and invest in following up 3 years later to see what the impacts were, that may be the time when short-term experiments looking at proximate outcomes, do people show up, do they attend regularly, what is their knowledge level at the end of the intervention. Those are all things that can be investigated relatively quickly, relatively cheaply, and may be more appropriate for early stages And then once you have, more of an idea of what your full model is, then you may want to invest in a larger scale, longer term experiment.
Actually, being nimble about this too, and always be thinking of possible innovations to test and try, I think is a useful thing to do.
Yeah. That opens up, well, before I turn to another question, did anyone else have thoughts on that?
Well, I just had a quick point. I think it's important that, I agree, it has to be ongoing. I mean, like in the education context, usually you're going to be doing this thing once a year in September or something. So it has to be planned ahead of time. Mm-hmm. I also think, in terms to get at the implementation issue, I think to get this off the ground, I think it makes sense to start with relatively simple interventions to implement, and to focus more on more of these mediator kinds of outcomes. So to make these things, conclude and show that they can work. So we're not going to be necessarily look at high school graduation or college attendance, but maybe attendance or attitudes might make sense to start this off.
Right. So this does lead to another set of questions. That relationship with the evaluator. If you're always thinking, always evaluating, it's one thing to have, as Renee exemplifies, sort of an in-house evaluation team. But in the case of the federal agencies in particular, for your programs out in the states, tribes, and so on, you're tending to bring in external evaluators. How does that work if you're wanting to really have that relationship, that engagement with the evaluator? Is it a matter of having planning phases, planning contracts, and evaluations? How would you envision that working?
So it's a fine line in between, what I described was a culture of continuous learning, which is definitely the culture that we're promoting, and the production of a lot of feedback information that we provide to the model participants in the program teams so that they can continuously change. Where I think in our organization on the evaluation side tend to sort of draw the line is while the evaluation team is producing all the artifacts that facilitate the learning, we have the evaluator stop from at the point of actually telling the site, this is what you need to do next and change. There's so that we don't end up in a situation where the evaluator is kind of evaluating themselves because they then have crossed over and become designers. We're fortunate that we have in our organization program teams that have the responsibility for the daily oversight and implementation, and a learning and diffusion team that helps the sites modify and change what they're doing. But the evaluator that we work with and the evaluation team isn't the one actually telling the sites, you need to change this. They're basically providing the information, and then it's up to others to decide what to do with that information.
Yeah. Naomi, did you have thoughts? Yeah.
So, there's really only one way to build relationships, whether you're talking programs and evaluators or any other partnership. You have to identify common interests. You have to work together over time. You have to build trust. But I would say a few things that are specific to this context. One is money talks. So, typically, at least since we no longer are in the AFDC context where we can impose a requirement on people to conduct random assignment evaluations, we are in a position of inviting state and local partners to participate on a voluntary basis in experiments, and it works. People are interested in learning. Not everybody, but it does work on a voluntary basis. It really can help if there's some money available to offset costs of participating in an experiment. It helps even more if there's money available to pay for some program enhancements. Technical assistance is important, and we've had models where the evaluator is providing the technical assistance to help the local or state program develop their enhancement, and that does, it can get into the situation that Renee mentioned where the roles are a little unclear. It helps if you can provide short-term feedback on implementation or short-term outcomes. And I've been in situations where participation is voluntary and situations where participation is mandatory. It's not as different as you might think. Even when participation is mandatory, you still have to do courtship and develop relationships and develop trust. It can be really helpful to have a mandate in your back pocket, but it's not as though you ever just get to say to people, do X. That's true in work, at home, anywhere. You always have to build those relationships.
Can I just add to that? Because we do use external researchers as well, and I think one of the key factors for us in developing that relationship is the external researchers having some experience and knowledge with administrative data. So for us to use an external researcher that has no idea what our data are, no idea what our programs are, it's just not realistic for what we want to do. So, we develop relationships with firms who we know our programs and maybe even have used our data in the past or have used similar data. So that's really, I think, critical from that aspect. And then just the other thing I'll comment on is the outside researchers really have to understand the realities of the program. So it's especially in designing experiments, because it's easy to say, oh, well, just implement it at these 6 and leave these 6 out, and we'll just do an experiment. Well, program managers, that's not what they hear. They don't hear how easy it is. They hear how somebody put it out there that we're already going to do it for every site. We can't possibly go back on that. So it's just a completely different reality. And I think sort of bringing yourself to that reality and understanding that as well as the evaluation side really is critical for developing that relationship.
Mm-hmm. Yeah. Others can respond to this, but Andy, I want to target you first. Jim Manzi from Brookings, I'm sure folks have heard speak. He talks about needing to build an experimental infrastructure into agencies, and I shouldn't say agencies, let's say systems or policy worlds. From your perch at OMB, where do you think that infrastructure could or should exist if we were to build it up so that these partnerships could be more ongoing, so that you could always be planning?
An infrastructure for experimentation?
Yeah.
Well, that's actually a tough question. Should have given me that one in advance.
You should have given me that one.
I think my mic isn't working.
Well, I'll say that Manzi does say that for education, it's the district level. But what about others?
Well, the premise that I think is useful to always, I'm not sure if this is the answer directly, but the premise that we always start with is understanding agencies' immediate and important challenges that they're facing. That's the place you always start with before even thinking about which tools or approaches. What's on the radar, on the minds, the priorities of the agency leaders? What are the challenges facing program leaders? And connecting these different offices that have expertise in these tools to leadership in these programs so that they can be resources for developing experiments or long-term evaluation, short-term evaluation, any of these tools. I think it always starts with the premise of what are we trying to answer, where are we trying to learn. That's my immediate reaction.
Mm-hmm. Yeah. Others have thoughts on that? You don't have to.
And just to come back to a point that Renee made a minute ago, I agree that we aren't telling them what to do, but on CPC, but rather how they might use the tools is something that we found. We give them all this data, and we try to keep it as concise as we can, but still there's a lot of information, and they're not used to looking at it. So we try to give them some guidance on, here's what you might do with this. Here's this comparison. You might look at your high-risk patients and see how you're doing relative to your peers in your region, and that sort of thing. And we also then try to get feedback from practices on how useful it is. And so we're always looking to try to refine these reports to make it as actionable and meaningful as we can from them.
Yeah. I would agree with that. That's the way that the information is being used. I think where the line gets drawn, though, is we don't tell the practices.
Absolutely.
And you ought to reach out to your high-cost or high-risk patients and talk to them 5 times a week.
Right.
That level of detail we try to avoid. But Randy's right. It's really important to help them understand how to use the information. Just providing information in the spirit of continuous learning can sometimes feel like information overload to the recipient.
Yeah, yeah. Well, we're at a point where I think we should turn it over to some questions from the audience. So first I'll invite folks here in D.C. If you'd like to ask a question, please, again, let me remind you to please identify yourself and where your agency, and please keep it to one question. John, right?
Yeah, John Barron with the Coalition for Evidence-Based Policy. I have a question for Randy and I have a question for Randy and Renee about the opportunistic experiments that Peter was describing, and to the extent to which you think they may be possible in healthcare, because it seems as if there may be, healthcare may be an area where there would be a lot of such opportunities. Just to give you a couple examples, one big problem in the healthcare system is that when elderly patients are being discharged from the hospital, many of them don't adhere to their medications, et cetera. They end up back in the hospital at very high expense, so there have been different methods used to try to manage the hospital discharge process to prevent that from happening. One could imagine randomly assigning patients who are already there, you don't have to recruit a sample, patients who are being discharged to either one hospital discharge method, a new method, versus the hospital's existing method, and then measuring outcomes, rehospitalizations, and health outcomes using administrative data from Medicare. And then the second example is an excellent study that Mathematica did back in the 1990s. It was a more traditional randomized trial, but where they randomly assigned 91 home health agencies to either be paid prospectively on a per-patient basis versus retrospectively cost reimbursement to see whether prospective payment would reduce costs, and it was found to. That was not done with administrative data, or partly with administrative data, but they also measured health outcomes the old-fashioned way. But it does seem like another case where you could, again, you had the sample there, you didn't have to recruit them, they were randomly assigned to one method, prospective versus cost reimbursement, and all outcomes potentially could be measured now with administrative data. So I guess that's the question. To what extent are there these possibilities for opportunistic experiments?
Yeah. The challenge is, of course, is getting the program operators to do it, because they're fearful that they don't like change. They got to train their staff. It's not a costless thing, and not so quick either when you have to go through all those steps and it has to go up the chain of command. Will the CEO of the hospital allow this? What's the payoff to us to doing this? They're interested in making money, not necessarily advancing learning. So it has to demonstrate a value to them, and you got to get people that are really interested in the process of learning. And there are some. The whole PDSA, Plan, Do, Study, Act thing that Ed Wagner promoted and developed so well, it's going on, this opportunistic kinds of studies, and lots of managed care plans. Kaiser does a zillion studies of its own all the time. So program operators are doing some of those kinds of things, opportunistic things, to improve their processes along the way. But whether you can do it centrally through a government program, that's not always the easiest thing. The home health study was not, for example, which I also worked on, was not one of these quick things. It was, people they applied and they were selected and randomized, and so it was more of the drawn-out process. But it's also possible once you get them, and I think this is the point you were making, once you get them into the program, then can you do some studies within that, like within the treatment group. And I think there is a lot of opportunity there. There's a technique called orthogonal design where, you got this program, you're doing prospective payment, but there's 18 different ways or components of the program to, when you go about implementing that, to provide incentives and provide information to the people that are doing it. And you don't have any information about which of those work. So you can create these designs where within the treatment group, if you can get them to play ball with you, they will each agree to implement a certain combination of these components as part of being a treatment group member. And then you can study that within the overall evaluation. So that has a lot of promise. And again, that's something that was stolen from another discipline. Advertising people do this all the time. So anyway.
I don't think I can really add very much to what Randy said. I said exactly what I would have said. That because we're in our organization and our agency basically are a payer, we're an insurance agency. It's for us to implement something requires recruiting participants to help us test something different than what's already part of the program. So I think the opportunistic kinds of interventions reside, as Randy said, within an intervention group from a mix of participants where you're trying to test or look at some nuance within the intervention among those who are willing and signed up to participate to begin with. But other than that, I think it's difficult to do.
I'll take another question here in the room, and in the meantime, I just want to remind our webinar audience to please submit your questions via the chat feature on the webinar, and then we'll turn to the webinar questions. Marcia?
Marcia Gold, Senior Fellow Emeritus from Mathematica. I wanted to ask a question of the more policy user-oriented people on the panel. One of the things that in the health field we're struggling, and I suspect it's other places, is sort of the distinction between generating knowledge and the relevance and use of that knowledge by audiences that are in the user community. And one of the questions I had was, do any of the new methods that you're talking about alter that equation at all and make it easier or harder or different for people to use it and who's using it and to make that connection?
Thank you, Marcia. Thoughts down at that end of the table?
I would say it alters the equation in the sense that it's providing information much more rapidly and quickly than we have in the past. To me, that's, I think, the biggest shift.
I would definitely agree. I would also say that some of the advances in information technology that make rapid experimentation possible also make more rapid, more tailored, broader dissemination of results easier as well.
And I would just add the rapid nature is key, but also the feedback points, because then program managers don't just look at it as generating knowledge, they look at it as knowledge that then they can make a change, and they can do it quickly.
That depends, of course, on the structure of the information you deliver to them, right? How you package that information for them to be able to apply it, though, right?
Right. Yeah, I think I understand it, and that's, I guess, because that's why the implementation piece is so critical, because you have to be able to link the outcome to how it was implemented, so that then you make recommendations about how you can change the outcome.
Exactly. Yeah. Crystal, do we have a question from our webinar audience? Do you need the other microphone? Oh.
We have a question from Harriet Arno. When using a comparison group in health services, at least, we have issues of protection of human participants in research. Our R&B and PMP has gray areas in defining research versus QI evaluation. Are there any areas that have found solutions to this?
Peter, I know you had posed that question too.
Well, that's a difficult question. Not all research studies with human subjects require IRB approval. I know in education, the federal regs say, research, quote, research conducted in established or commonly accepted educational settings involving normal educational practices, such as research on the effectiveness of a comparison among instructional techniques, curricula, or classroom management methods, do not require IRB approval. In practice, there's a big gray area, so that's not a solution. But I guess if you could argue that the regs pertain to your study, it may, you may be able to circumvent IRB approval. So that might suggest how one might pick interventions to avoid the IRB OMB approval process to make these things more rapid.
Actually, in the health area, as long as it's being done to improve their performance, then the IRB is not needed for most kinds of health interventions. So a managed care plan can do what it wants, or we can do an evaluation for them because it's classified as a program improvement process that they're supportive of this kind of idea of continuous improvement. So.
Right. Right. Good.
Anne?
Oh, go ahead. Sorry.
So I find it helpful in the human subjects area, which is very complicated and has many subtleties, and I can't always wade my way through easily. But I find it helpful to go back to what I see as the core principles, which is human subject protection is to protect people from being used as a means to an end. So the reason there are higher standards of protection in a research context than in a policy or improvement context is for that very reason. So program managers or healthcare providers can make all kinds of changes for the benefit of the people that they're serving without going through an IRB approval process. But when you stray over into a research context where you are doing the research not necessarily for the benefit of the people actually participating in your study, but for a broader or future purpose, that's when you need to be especially careful about how you're treating those people.
Mm-hmm. Thank you. Thank you. Scott?
Scott Cody with Mathematica. This is a question for Angela. I'm curious, I assume that you have a lot of things, interventions that you'd want to test. And can you say a word about how you prioritize what comes into play when you're deciding which things you're going to run an experiment for and which things you're not?
Right. That's a good question because you're right. There's many more things that we would like to test than we really can. Part of it is priorities at the time, which is also why the rapid nature of what we do is very important because priorities are constantly shifting. And so we do tend to focus on things that have that we're able to do quickly and get feedback to the program managers quickly. We have done more of the traditional long-term evaluations that take 2 to 3 years before you have any sort of impact. What tends to happen is the program ends way before we have a chance to even look at the long-term outcomes. By the time we present the results, it's not relevant at all. There's been a change in administration. There's been, all of these things. So it really does, in our work at least, come down to what is the priority at the time and what is going to be most beneficial at the moment for the program areas. When we do the longer term, we do tend to go to the the external researchers, and maybe it's ACF is interested in something that's not it's related to what we're doing, but not directly related to the day-to-day operations and the priorities at the time.
Do we have time for an additional question or two? Okay. How about if we turn to one more webinar question? Sure.
How do we get more evaluations published in the peer-reviewed literature so that findings as well as promising programs can be generalized?
This actually, I think, gets to a point Peter made in talking about building an evidence base. Do you have thoughts on that?
Well, I think, to be honest, traditionally, impact evaluations, it's very difficult to publish those results in mainstream journals. That's changed recently. For example, evaluation review now encourages random assignment studies, even with 0 findings, to be published. So I think that's important. You do see there's journals popping up in various disciplines. For example, in education, there's a journal on research and education effectiveness. That's all about RCT, randomized trials. And so I think it's becoming more mainstream than it used to be.
Yeah. All right. Well, we're going to have to wrap it up as time is up. We hope you've enjoyed today's discussion. I would encourage you all to let us know what you thought using your comment card in your packets, or for those of you on the webinar, responding to the electronic survey that will be sent out. And I hope to see many of you at our next CIRE Forum, which we have planned for September 30th, and it will focus on implementation science. Thank you.